turn off the videos and the microphones so Prof Mehtar can have the opportunity and very nice internet bandwidth to communicate with all of us. So please turn on your microphones and your videos for the first 5 minutes so we can actually have the contact before we start. Thank you so much.
Can we start the introductions, Andy, please?
Yes, so we start with Marceline. Please, can you introduce yourself very briefly?
Okay, I'm Marceline Maguzi from the Infection Control Association of Zimbabwe. Nashamba here.
Welcome.
Hello.
Please, Ninette, can you introduce yourself?
Afternoon, everybody. I'm Nanette. I'm from South Africa. I'm from a company, FAFMed. We look at infection control within the CSSD environment.
Okay. David Nyukuri, can you introduce yourself?
Okay, thank you, Andy. Hi, everyone. My name is from Stellenbosch University.
Salute. Yeah.
Afsa, can you introduce yourself? Afsa? Okay. Lynette, can you introduce yourself?
She's moved to, oh, there she is.
Lynette?
Unmuted by the host. You're unmuted by. Hi
Yes,
there.
welcome.
I'm the nursing manager.
Okay, welcome. Prof Robertson.
Thank you. Thank you.
Prof Val.
She's muted.
Oh, sorry.
Oh, no, now we can hear you. Now we can hear you, please.
Oh, I wasn't muted. Yeah. Okay. Did you get my introduction?
No, not yet.
Oh, I'm Val Robertson from the Infection Control Africa Network and from Zimbabwe.
Welcome, Prof Robertson. Nellis Vancel.
Hi, I'm a medicine physician in George. I'm in South Africa.
Welcome. Kevin.
Kevin's muted.
Kevin. Okay, Stephen.
Stephen. Okay.
Well, for the sake of time, I think we should just carry on as we have many participants, about 34. I mean 34, which is quite significant. So we should start now, and I'm inviting Prof Mehtar to start with the talk. Thank you. Welcome, Prof Mehtar.
Thank you. I'm terribly sorry we didn't get a chance to talk to everybody and to introduce everybody, but it's really quite important that even if you didn't get a chance to introduce yourself, please, when we have our little discussion, everybody should participate. So as you know, I'm Professor Shaheen Mehtar. I'm supposed to be retired, but I'm now forcibly retired because my foot is broken and I can't go anywhere. However, we're very involved with the national and the WHO as on the expert panel on coronavirus, and I am the education working group chair for the Infection Control Africa Network. So I thought the best thing to do for me would be to share my share the experience that we have from South Africa at the moment. We, as you know, have had 7 cases so far, possibly 8 coming up. Okay, so I'm going to use that as the case study for us to talk and discuss matters. All right. So if we start off by first of all just going through what happened, I'm going to talk about the case study. I'm going to pause. I want you to ask questions and discuss matters. And I was hoping that people who have had cases like Bimbo from Nigeria, Cameroon, or Senegal can probably contribute. And then we'll go into what we've organized as a part of the dialogue, which is, of course, a movable feast, because we have to change it depending on what the situation is. So the case study for the SARS, COVID-2, which is also known as COVID now, it's been called COVID since February 2019, is as follows. My disclosures are none. And as I've just mentioned, we'll go through the case, the discussion, and then the various didactics. Unfortunately, we're not in a position to be sitting in the ECHO office because of various reasons, but I'm going to try and do my very best to try and show you what I can. So this is a case study where a 38-year-old man returned from Italy, where he was skiing with his wife and 2 children. And he came back on the 23rd of February. On the 3rd of March, which is 3 days later, he developed flu-like symptoms. And being very clever and smart, he went to his nearest health practice, that was a general practitioner. He mentioned he'd been to Italy on a skiing holiday. And he also mentioned that he was concerned about what was going on. So he then had a nasopharyngeal swab taken for COVID. On March the 5th, he was found to be positive. So the question is, what actually goes on in these ski resorts? And one would have thought that if you're standing in the mountains in the Alps somewhere, that you'd be wide open spaces, nobody around you, not much going on. But if you look at these pictures of what the après skis and some of the other areas are, it's a really, really crowded area. And it's not surprising that people are sort of crowded into each other. But also, I wanted to just go back to the, oh dear, okay, previous. But even when you're living in chalets, there are lots of people crowded together in small areas and small chalets. So what was of interest is that the 10 ski party that went from South Africa all stayed in the same chalet. And I'll come back to that. So he was told to go under self-isolation, which he did very effectively, and I'll talk about that. His wife and his 2 children were tested somewhere between the 7th and the 8th, because this is when the NICD and the National Department of Health immediately sent out people to the province in which he was living, and to investigate and to meet him. The doctor was very smart as well. He put himself into self-isolation. And the nasopharyngeal swabs came back on the 8th, where the wife was positive, but the children were negative. So the story is that there were 10 people in the same skiing party who lived very closely in a ski resort. They were from different parts of the country, but many of them came from one province in particular. One of them remained in Italy, and 9 of them came back. And this is our first case. So the tracing would be, they flew from Italy to Dubai, directly home to the hometown, on the 1st of March, 29th of February, felt unwell 2 days after arriving, 3rd of March. But the thing was that his son goes to a very prestigious school, and there was total panic at that school, and that was interesting. The second case was a businesswoman from the same group who came home a little bit early, 28th or 29th of February. She developed respiratory symptoms and sinusitis. And being a CEO of a company, she persevered and carried on thinking she just got flu. She was not picked up at Port Authority, and she was not linked to the ski party till much later, which was on the 3rd. She went on to work. She went to a big board meeting with a whole bunch of people around her. However, it was a big boardroom. There was lots of ventilation, 2 meters between them, contact. Okay. So because she had the sinusitis and not feeling ever so well, she was caught up as part of the 10 or the 9 now of the ski party, and was tested on the 7th of March and found to be positive. So the transmission looked like this. This was the father on the 5th. This was the GP who went into self-isolation. This was the woman who was symptomatic. Dad was symptomatic. She was symptomatic. This was the wife who was asymptomatic. And these were the 2 children at the time that were negative. following from that, there were these 6 that had to be found and to be isolated. And I have to commend the National Department of Health for doing a fantastic job. So the point is that if you're doing contact tracing, and this is probably the most tedious part of trying to sort out an outbreak, and those of you that have attended courses with us and the postgraduate diploma and FIPC know that when we talk about an outbreak, it's not nearly the same as doing it yourself. So they have to do a line list with the name, the age, the job, the address, the phone number, the email, and so on, and trace all the immediate contacts. And the question is, who are these immediate contacts? So in order to manage something with low resources, we have to ourselves use our knowledge to say what is a high risk and what is a low risk group, so that you can start with contact tracing and isolating, and taking samples from the high risk group then to the low risk group. So we decided that the high risk group is obviously the wife, which is true, the children, the ski party that live very closely together in the 10 days in the chalet, those that were closely socializing. So I'd imagine because they were out as friends, they were socializing closely together. They were sitting next to an asymptomatic person on the plane, or to a symptomatic person on the plane. So these are what we said were high risk, and I would like you to contribute to that. A low risk could be meeting up people on piste, in other words, on the ski slopes, distance from the index case while traveling, so you're sitting 6 rows behind them, meeting in a boardroom which is more than 1 meter, 2 meter spacing, which was there, and you are good with hand hygiene and there's a good cough etiquette in place. Now this is quite important because out of the, as far as we're concerned, that group of 9 is a common source outbreak at the moment. And the idea is that we don't want local transmission. That is my mission as the person that's leading up the IPC program for this particular group. So we had to make sure that using that fact, that those criteria, we did total screening for these 9 people of 300 contacts. Now that is a huge amount of screening. That's a lot of work. But this lady who was the business CEO had lots of contacts. The father, the wife, you know, other people around. And when we picked up from the common source, was that 4 other people now turned purple, which means that they were asymptomatic, but they were found to carry the the COVID-19 virus. 2 people were found to be negative. This was a couple, a husband and a wife, and then the other one were contacts, okay? Right. So this is tracing contacts, which is the worst part of it. And you have to retrace the person's step more or less yourself. So the question is, from my point of view, this is what we say: ski chalet in Switzerland, nothing we can do about it. Okay, we're too far away. How many people from where, distance and the distant and low risk? Yes, we can assess it. How many in the ski party from this country, which is our responsibility, were close and were high risk? That is what we were. So on piste, nothing. Après ski, close contacts, both high and low. Airport in Dubai, 1 in Italy, then in Dubai, low risk. Airport seating, 2 rows in front and behind, sharing the same ventilation, fine. Arrive at home, low risk unless family picking one up. Driving home is fine. So this was the contact that we had immediately coming and going through it. Each of the person were to be found was going to be told to self-isolate. They'll have a nasopharyngeal swab taken. If negative, then they can come out and go off and do what they like. If they're positive, then they're going to stay there for 14 days. So the Minister of Health in South Africa, Dr. Mkhize, who has actually been amazingly hands-on and very, very involved and knows exactly what's going on, every day does press conferences, every day does communication, and then drags us out in the middle of the night to do lots of other work, has made sure that everybody, whether you're symptomatic or asymptomatic, will go to a public hospital where you will be admitted for the time till you become negative with your nasopharyngeal swab. Okay, I mean, this is really quite important. It's not something that everybody has done, but we've done it because there are several reasons for it. So the question I'm asking you is if I can just stop sharing here and ask you that, do any of you have experience in your own countries of dealing with the coronavirus at all? And if so, could you share experience? I was hoping Kevin might say something, or Bimbo might say something, because they've got one case in Nigeria. There's now a case in Cameroon. there's two cases Cameroon, one case in Senegal, and so on and so forth. So South Africa, we've got our 7 out of the 9 at the moment. So I thought we'd stop here. I'm 15 minutes in, so maybe 5 or 10 minutes of what you guys are thinking or ideas or whatever.
So welcome everyone to this discussion. I think we should participate now for a few minutes before we can move forward and have a didactic lecture. So please, everyone who has got experience with dealing with coronavirus or COVID-19 is invited
or
to,
even if you haven't got experience, if you've been
share
doing any
something.
policies or documents, if you've done any policies or any documents, or you are preparing yourself for COVID-19, can you tell us what you do?
Can I talk?
Yes, please.
Yes, please.
Yes. For us in Nigeria, we have one case. It's a 44-year-old Italian that flew in from Milan and came through Lagos and went to a hotel somewhere in Lagos in Ikoyi. From Ikoyi, he came on a business meeting. He moved to the next state of Ogun State, but took ill and went to the clinic. And that's why he was picked up. Of course, like you said, they had to retrace his steps with all his contacts. He was brought back to Lagos and was admitted into an IDH, infectious disease hospital. But as at yesterday, it was the only contact case. There's been some other people that came in that tested negative. But yesterday evening, one of his contacts became positive. So right now we have 2 in Nigeria, but they are trying to now locate the contacts of the new case. Actually, this morning, the names is in public for them to show up so that at least they can be tested and served. So I think that's the experience we have so far. We've had 3 cases isolated, only 2 confirmed cases now. They're still trying to trace the contact of the second case. But the one case we have is responding, his viral load is dropping. It's a mild case. We just hope that it doesn't go beyond that. So there are 2 cases. Yeah.
Okay, thank you. So the guy that was the second contact, he actually surfaced after 7 days.
Yeah. So luckily, he's been in isolation. He's been quarantined, and because they've been testing regularly, he became positive yesterday evening. And the minister, at least had a press conference to say we have a second case. But they are now trying to trace his own contacts.
Okay. No, this is very important, Bimbo, because we need to know that if somebody has gone into isolation and they've self-isolated or whatever, how long do they need to self-isolate for? And you make a very valid point to say that the guy's been in there for 7 days and now he turns up to be positive, whereas many times for flu or whatever, we'd expect them to go home after 7 days. So in his case, that's an important point for us to remember. Thank you.
Yeah.
Okay.
Yeah.
Anybody else? Any ideas? Anybody? Anywhere? I know that.
I had a question.
Hello.
Sorry?
Hello.
Hello.
Yeah.
This line.
So Linus first, then the second one.
Okay, it was me, Robert. Okay, I will come.
Okay, thanks. Thanks for those case presentation, and thanks to hear from Nigeria and South Africa. In Kenya, we've not had any case identified so far, but we've had about 17 alerts, and all of them turned negative. We're still having our contingents planning, developed, and training and sensitizing the community and the healthcare workers on what to do in terms of contact tracing and identifying cases using the case definitions that has been adapted from the WHO. So basically for us, we continuing with the preparation and sensitizing the healthcare workers in case of any case that can be identified. And we have really widened our net so that it's all port of entry, that we have trained our staff, so, and they understand the case definition, and our media is also trying to educate the community on steps that they need to take. Thank you, and over.
Thank you, Linus. We will go into that when I do my presentation, but that's really helpful as a taster and as a start for what we want to do. Robert, were you going to say something?
Yes.
Yeah, thank you very much, and thanks for the overview. I had a question actually to Bimbo.
Yes.
And my question is, most of the the cases that have happened in Africa have been foreigners or some people who have gone to foreign trips. I wonder who is this second case. Is it a national? And how is the
Is a national.
Is a national.
Yes.
Okay,
yes.
so it's something that has the transmission is likely to have taken place within.
Yeah.
Okay,
yeah,
I just wanted to know that.
Yeah, it's a community transmission.
So that is, yeah, because I think the one thing that we're going to be talking about is the difference between source transmission and local transmission. So this person that has had the local transmission has not got any other risk factors of communicating with people who are COVID-19 positive.
All right, thanks.
Okay. Bimbo, is that true that the only person, this COVID-19 positive national, the only risk factor he's got for it is the contact with this Italian chap?
Yes,
right?
with the index case. Yes,
yeah.
That's the only contact.
Okay,
that's for
fine.
now. Yeah, as of today, that's it for now.
Okay, well, I think that's a really important point, and I think we'll come back to that. Is anybody else who wants to offer some information? We are, because then I'd like to go on to the talk itself. Anybody? Any ideas, any thoughts? I think there'll be a lot of discussion after that as well. So let's just see how we go. And if you don't mind we go to share again.
So Prof, I will invite everyone to post in the chat section any question or comment, so we can keep moving while we have the comments in the chat section as well.
Okay.
Yeah,
right.
Thank you.
All right. So let's go on and see what's, where are we here? Okay, so from the current slide. So we've discussed that. So this is as of the first. So what becomes everybody, this is a classic situation where we're looking one way and something comes and bites you in the bum from the back, you know. So everybody's looking at China here, as you can see. This is the WHO case since the 1st of February, going till the 5th of March. There's China, there's Wuhan, there's where everybody's becoming very nervous about various things. And they have managed to, with some very draconian measures, and I mean some seriously draconian measures, managed to contain. And there they go, they're containing that and they bring it right down. And then of course we'll end up with this pile here, which goes up. And we know that this is still going up, particularly with the Italian situation that we are currently seeing in Europe. The one thing I want to bring to your notice, and I really would like this discussed. This is my take on it. The flu season in the world is now in the northern hemisphere around here. Okay. This time, I hope I've got the equator line right. I couldn't see it very well, but here's the equator line going through there. All right. So everybody in the northern hemisphere, this is what's going on over here. These are the higher temperatures in the southern hemisphere. And the question is, why is Africa not seeing a lot of this corona outbreak? And a lot of the accusations in the press and the media and so on have been, oh, well, we don't have the capacity, and we don't know what we're looking at, and life is like this and like that. No, I don't think that's true. I think it is to do with the temperatures. I think it is to do with the fact that in the southern hemisphere, which is much warmer, the virus has difficulty because it's a winter virus, it's a flu virus that likes to spread around. This virus has difficulty taking hold. And in our part of the world, people go outside. They sit outside when it's hot. they get a lot more ventilation and so on. Whereas when it's cold, everybody huddles together. They all come into the house. They're all sitting tightly together. And that is probably one of the reasons why this sort of thing is happening around here, I think. So it's the overcrowding. It's probably a lot of spread of droplet back and forth, which causes problems. And I just wanted you to mentally lay this particular map of the number of cases on top of the one that I just showed you. So you can see that this is actually where the equator sits, maybe a little bit higher than that. And then you've got all these cases happening in the northern hemisphere. So what this tells us, or this I think to my mind tells me, is that if we're going to see it in Africa and in South America, if they do not contain it by then our cases will be happening from June, July, August, and so on. Okay, if we contain it before then we're all happy. But you would say, well, what's happening here in Australia? Well, this is true. It is in the southern hemisphere, but there has been a lot of activities, you can see, of coming and going and people moving around and a lot of tourism. So there's tourism, there's cruising, there is other sorts of activities that go where people huddle together, including ski resorts and such. And I think those are the areas that we have to avoid and make sense of. And therefore, just giving a combination of the two, where Iran, China, and Italy are all sitting, and America and so on, are all sitting in the northern hemisphere. There aren't any 1 or 2 cases down here, and as we just heard, 2 cases there. We've got our 7 positive, of which 2 are symptomatic, etc. So that's the first thing I wanted to make. I just want to show you this video about coronavirus, rather than me going on and on and on. I think you should do it. Just have a look at this.
Pneumonia cases in China. Investigations found that it was caused by a previously unknown virus, now named the 2019 novel coronavirus. In this video, we'll take a quick look at what's currently known about the virus. Keep in mind that this is a new virus, and what's known about the virus now might change in the future. Coronaviruses are a large group of viruses. They consist of a core of genetic material surrounded by an envelope with protein spikes. This gives it the appearance of a crown. Crown in Latin is called corona, and that's how these viruses get their name. There are different types of coronaviruses that cause respiratory and sometimes gastrointestinal symptoms. Respiratory disease can range from the common cold to pneumonia, and in most people, the symptoms tend to be mild. However, there are some types of coronaviruses that can cause severe disease. These include the severe acute respiratory syndrome coronavirus, first identified in China in 2003, and the Middle East respiratory syndrome coronavirus that was first identified in Saudi Arabia in 2012. The 2019 novel coronavirus was first identified in China. It initially occurred in a group of people with pneumonia who've been associated with a seafood and live animal market in the city of Wuhan. The disease has since spread from those who were sick to others, including family members and healthcare staff. There are many cases at present, and the disease has spread within China and also to a number of other countries. So, where did the virus come from? It's known that coronaviruses circulate in a range of animals. Sometimes these viruses can make the jump from animals to humans. This is called a spillover and could be due to a range of factors, such as mutations in the virus or increased contact between humans and animals. For example, MERS-CoV is known to be transmitted from camels and SARS-CoV from civet cats. The animal reservoir of the 2019 novel coronavirus is not known yet. How is it transmitted? The exact dynamics of how the virus is transmitted is yet to be determined. In general, respiratory viruses are usually transmitted through droplets created when an infected person coughs or sneezes, or through something that has been contaminated with the virus. People most at risk of infection from the novel coronavirus are those in close contact with animals, such as live animal market workers, and those who are caring for people infected with the virus, such as family members or healthcare workers. So, how does the disease present? Well, from what is known so far, there can be a number of symptoms ranging from mild to severe. There can be fever and respiratory symptoms such as cough and shortness of breath. In more severe cases, there's been pneumonia, kidney failure, and death. The mortality rate is not known yet. How can we tell whether someone is infected? The infection can be diagnosed by a test called PCR, or polymerase chain reaction. This test identifies the virus based on its genetic fingerprint. There's currently no specific medication for the virus, and treatment is supportive care. There's currently no vaccine to protect against the virus. Treatment and vaccines are in development. How do we prevent transmission of the virus? This new virus currently has a limited geographic spread. However, there are a number of standard hygiene practices that have been recommended to protect against infection and further spread. These include covering your mouth and nose when coughing or sneezing with a medical mask, tissue, or flexed elbow, avoiding close contact with those who are unwell, the appropriate use of masks and personal protective equipment, especially in a healthcare setting, washing hands regularly with soap and water or alcohol-based hand rub. Actions that can be taken to prevent infection from an animal source include avoiding unnecessary unprotected contact with animals, washing hands after contact with animals or animal products, and ensuring that animal products are cooked thoroughly before they're consumed. It's important to stay home if you're feeling unwell, but if you have a fever, cough, and difficulty breathing, seek medical care early and share your previous travel history with your healthcare provider. That's a quick look at this emerging infectious disease. Given that this outbreak is evolving rapidly, what's known about this virus could change. Please check the websites below for the most up-to-date information.
Okay. So I think the video sort of tells us what we need to know very basically, but more importantly, things have changed since then, because they were saying it was geographically limited to Wuhan, but in fact it's not. Things have moved along dramatically all over the place, and now they know that it will affect the elderly over the age of 60, will be much more affected than children. We now know that there's a huge issue around when the shedding takes place, and I'm just going to go into that with you now so that hopefully you'll understand a bit more about that. I'm sure there are questions arising from this, because some of it links to us and some of it doesn't. So they're saying that the most important part of it is shedding, which is peaks at 5 days post-onset, which sort of fits in very well with Bimbo's second case, when 7 days after the first one was diagnosed. Therefore, 5 days high shedding, 2 days for the person to develop symptoms, and that's 7 days. So that's 1 week into that. Shedding can be detected in 48 hours prior to the disease onset. Okay. Isolation from the stool, but there's no epidemiological evidence. I totally agree. It's a respiratory virus that needs to get into your respiratory tract and not orophycal at all. And this will carry on for up to 12 days, they believe, for up to 2 weeks. We're not sure, but I think if you're mild and asymptomatic, I think you probably can do it better there. So the transmission dynamics that happened in China were quite clear that, in fact, the majority of the cases were close contacts. There were family clusters, 10% transmission earlier on, and then after that, it sort of started spreading. So they said, why isn't it happening in children? I'm just going to escape here because I want to move this thing out of the way. This is just something, here we go. Okay, so the family clusters was made. They said no children transmitting to adults, which is very, very interesting. 10% transmission in early outbreak, which fell to 3% with fast isolation. So the message here, the take-home message here is we need to isolate as soon as possible, which is why we did the high and the low risk thing for low and middle income countries, or for South Africa anyway, so that we could immediately identify those that we really need to concentrate on and those that we can actually look after when we've got more funds to do so. The other close setting is happening, but there is, of course, the healthcare facilities, yes, no, homes, and again, crowded areas, you know, nursing homes, prisons, etc. And they said they don't have school outbreaks because there's nobody there at the moment, which is fair. So basically, 80% will be mild or moderate. So the panic that's caused across the world is nothing to do with the virus, but to show, and if I show you this picture down here in the corner, that there is somebody standing there in a hazmat and this, that, and the other to go and see a patient who's probably just sitting there with a little bit of sniffle. Okay. And I think it's very important how we give this message out there. All right. I prefer the infection control practitioner on the top of the picture here who knows what's doing. They've covered their face and they've got gloves on. And this person down here is obviously somebody who doesn't have a cooking clue what's going on in infection control. So severity is 15%, critical is 5%. The progress is that most of them will, some might, 15%, 10-15% become severe, and some of them might go critical. So it's not that bad, as it were. Exposure to symptoms, as Bimbo showed us, was 5 to 6 days. Symptoms to recovery, 2 weeks, 10 days, something like that. Symptoms to recovery from severe cases is very, very important because they have a lot of respiratory damage, secondary infection with bacteria, possibly even fungal infections if you don't treat them properly, might need ventilation. And so therefore 3 to 6 weeks. If they're going to die, they normally do it within the first week or two. Okay. Other than that, they drag on. Having said that, the 3 cases recently that died were after a month in the intensive care. The one case of the German chap who was in Egypt, he passed away after a month and a week, 5 weeks in the intensive care unit. So truly asymptomatic people seem to be rare, but we're seeing them more and more now in healthy adults. 75% of them will soon progress to disease. Well, our patients have not, our positives have not shown that. In fact, they've all got up and gone home from the isolation. Children are milder disease than adults, which is good to know, but we can't give you records because schools are closed. I'm going to just show you this video again from the WHO, hopefully a very short and brief one, which will give you a reasonable idea what to do.
These droplets can land in the mouths or noses of people who are nearby. These droplets are too heavy to travel far in the air. They only travel approximately 1 meter and quickly settle on surfaces. This is the reason person-to-person spread is happening mainly between close contacts. The exact time that the virus can survive on surfaces is not yet known. So it is wise to clean surfaces regularly, particularly in the vicinity of people infected with COVID-19. Hands touch many surfaces which can be contaminated with the virus. You should therefore avoid touching your eyes, nose or mouth, since contaminated hands can transfer the virus from the surface to yourself. When coughing or sneezing, cover your mouth and nose with the bend of your elbow or use a disposable tissue. If a tissue is used, discard it immediately into a closed bin. The most effective way to prevent the spread of the new coronavirus is to clean your hands frequently with an alcohol-based hand rub or soap and water. This will eliminate the virus if it is on your hands. Stay healthy and prevent the spread of COVID-19.
Okay, good. So the next thing I want to say, there's been so much misinformation, there's been so much unnecessary practice, such a huge amount of cost and expense, and those of you that are well-trained infection control practitioners are probably falling off the chair just laughing at this sort of behavior here. There's one chap standing here, he's got all his goodies on, I don't know where he's going. There's another one here who's just sort of spraying this poor woman who's come out of the shops for some reason. And the thing is that you have to keep reminding yourself that this is droplet, okay? It's not airborne, it's not bloodborne, it's not. So what they've done is they've just taken stuff from Ebola and transferred it directly onto this, onto the COVID-19 program, thinking that that is the way it spreads. And this is absolute waste of money and absolute waste of time. Therefore, for low to middle income countries, I'd strongly suggest that's not a good idea. Okay, so hand hygiene, we know, social distancing up to 1 meter or more, cough etiquette. If you're over 60, we'd like you to stay indoors as much as possible or avoid crowded areas. We'd like to keep the environment clean and dry. You can use alcohol wipes or whatever else you've got. I think that if you're flushing the toilet, I think it's best to keep the lid closed. And if you want to go exercise, please do. I mean, go out for a walk. Go walking around the park if you're not too sick to do so. Just avoid crowded areas and go into the open fresh air would be great. So the question is, what is self-isolation? This is where you keep a daily temperature of yourself and make note of any flu-like symptoms. You socially distance yourself from other members of the family. We prefer you to have a separate bedroom. You can eat in the room, but I personally think it's ridiculous. I mean, so if you're actually sitting at a dining table, which is 1 meter, 1.5 meters away from everybody else, there's nothing stopping you doing that. And I think that's quite a good way of, because it's really difficult to spend 2 weeks on your own with the rest of the family around you without having to do anything else. You can walk in the fresh air, you avoid crowds, and you can call the number which I've taken off here because I don't think you need to know our number, but we have a number and the response is quite good. So what you then do is in that 14 days, you wait for the swabs. If the nasopharyngeal swabs are not done for some reason, which I don't think will happen in South Africa, but might happen in other low to middle income countries, you will then wait for 14 days to make sure you don't have any clinical signs of infection. And then you can go out and behave as you want. If you are in home isolation, and this is quite important from the self-isolation thing, you're looking, if you're symptomatic, you need to have hand hygiene, cough etiquette, in a clean, dry environment. And sorry, if you're asymptomatic, apologies, asymptomatic. If you're symptomatic but not requiring hospitalization, you're best left in your room. Please open the windows. Please make sure there's excellent ventilation. And I haven't said that here, but I just took it for granted. Hand hygiene, you wear a mask if you leave the room. There are no visitors in the room, but you can meet them in the lounge, sitting quite far from them. And if preferable, go and sit outside under a tree or something. And if you're very, very unwell and nobody can admit you, in South Africa, this is not so because everybody has to go to hospital if they've got signs of corona. But if you're outside, then you have to have a designated caregiver who will be taught how to handle you. Okay. For infection control people, moderate, non-ventilated caregiver, in other words, the hand hygiene, surgical, this is the healthcare worker. Surgical face mask with the shield, goggles, plastic apron and gloves. ICU, then you go into the N95 respirator, goggles, water resistant, and gloves. So I think that's quite important. This is, for those of you who don't know, this is Professor Mark Mendelsohn, who is the Professor of Infectious Diseases at the University of Cape Town. He's also the current chair of the Infectious Diseases, International Society of Infectious Diseases, and is an ID physician, but has got leanings towards good infection control practices. And I thought it'd be really nice to be able to show a video of one of our own taking part in this, because it's so confusing, this donning and doffing thing. So this is a real clinician about to work with a patient in a real given situation. And I think you should watch it. If you don't like it, just tell me and we'll take it off. But here we go. Okay. Okay, so I'm going to come back and talk about that in a minute, but just finally, I want you to look at the communication with the public. We have to be very transparent, and we're very delighted to say that most of the people on this particular time, particularly in South Africa, including the minister, have been very, very transparent, keeping communication lines open, lots of information in the media so that we give them the correct information and then they don't listen to nonsense. Therefore, we can say there's no to wearing hazmat or applying alcohol to gloves or spraying the environment. We're also talking to lots and lots of people on media, making sure the same messages are going out. We discredit all the fake news, the home remedies, and all the nonsense that's found on media. Okay? So this is the final message from me and from ICAN, is that we are trained in infection control. We have evidence-based guidelines. Please don't get distracted. And please do not move towards misinformation or rhetoric, albeit on social media or whatever else there is. So on that happy note, I'll stop, but I think we can actually talk about some of the points that I have raised, and we still have a good 10 minutes to go. So the first thing I wanted to say was about the fact that we had Mark to do the demonstration, which I was rather delighted with. He's a typical physician and has done a super job. And all the bits that happened as he was doing it were very close to what normally happens. So when you're putting on your gloves, you will knock something over. If you're dropping something in the bin, you might fall to the floor. You've got to pick it up and put it back in. But the point is that we should be talking about, if you're doing this for COVID, you're looking at non-sterile gloves. This is low to middle income country stuff. We are reusing our goggles. Okay, we're cleaning them with alcohol and reusing our goggles. Aprons instead of these really hazmats and all that sort of stuff that everybody is using, but we are not reusing on N95 respirators. So because everybody else is going to use a face mask, it's only if you're going for an aerosol generating procedure that you will be thinking about using an N95 respirator. So that will most likely be 1 or 2 a day max, unless you're going to Italian situation, in which case you'll be living in one of those. But the thing is that is what you want to know. Okay, that's really important to understand that. Otherwise, what will happen, particularly in a country like South Africa, where we've got a high burden of TB, about 2 weeks ago, we got to the stage where there were no N95 respirators left in the Western Cape because everybody was using them to stop getting coronavirus that hadn't even existed in South Africa. And that meant that we couldn't deal with any cases with tuberculosis, multi-drug resistant, or otherwise. So it's really important that we put into perspective from our point of view as infection control practitioners to remain sensible about this. So those are the points I wanted to make. I also wanted to just mention the mortality rate was from Chinese studies were 2.7%, but the Italian study is 6% because they have a very large elderly population. And many of the people living in Milan and all the areas around there are about 90 years old. Okay? So I'll stop there and then you guys can come back and talk to me about whatever you want to. Bimbo?
Well, I think that was a beautiful and brilliant presentation. It's a lot of heads on. Nigeria had the experience of Ebola, and I think we pick it up from there. So the structures were on ground. As soon as the case came, I think, like you said, I want to agree that the temperature must be responsible because we've been wondering, because since Ebola, the system got a bit weaker. Everybody relaxed. And I was a bit scared that now this coming, are we really ready for it? And I think the temperature is helping out. And everybody has farm up, you know, that already structures in place, training going on, you know, involving the community, education, and all that. So I want to pick on that temperature, and then the elderly. We are lucky that the Italian that came is 44, is under 50. So apart from, and then you mentioned it that the frequency, the mild, I think he just had a mild infection. So I think we are lucky about that as well. So I just hope that, you know, we just carry on whatever we're doing. But everybody should be careful that even with the contacts, after 5-6 days, they can turn positive. So we should make sure we just, have the structures and make sure we quarantine and keep checking and don't relax.
Thanks, Bimbo. We just have some questions here now. Thank you very much. Sorry. I mean, did you want to? Sorry, did I cut you off? Was there something else you wanted to say? No. Okay.
No.
So there's a question here from David, who asks whether to ensure maximum prevention in Burundi, the MOH systematically, where's it gone? Put in quarantine people coming from hotspots such as China, Italy, Iran. The main reason was that some of them infected tested positive, whereas they were asymptomatic, which means they can't be identified during the screening process. Absolutely right. And if that's what you guys want to do, and if that's what helps you, and you can put it into place, not a problem. Put it there and let it happen, okay? The second question is from Red Cross, which they're asking about the surgical mask to be used for all cases except procedures, and the answer is yes, yes. You have got the national IPC guidelines from the NICD. You have the national asymptomatic and symptomatic management guidelines. All of you should have those guidelines. If you don't have them, get them at the website from South Africa and ICD. If you haven't got them, get back to me and I'll get them to you, okay? Then the other thing is for frontline staff seeing a high volume of patients, are aprons enough for them leaving to go home to the family? So it's a droplet issue. And as you saw, Professor Mendelsohn showed you that if you're bare below the elbows, you can do your arms before you go. Don't forget it's droplet. Okay, it's droplet. So you have to touch the surface and stick it up your nose before you can get it, if you want to get it in that way, or you're going to have to get that to cough. So if you're wearing an apron, unless you touch the apron on the outside, which is contaminated, not do your hands, okay? And that regular hand hygiene requires you to do your hands before you go home, I presume. It's the same as when you're leaving work. You must do that, okay? So therefore you will do that and your hands will be safe and you'll be allowed to go home with just an apron. It'll be fine to do so. Oh, sorry, so that's Marston. You're welcome, Marston, okay. And then Vida, Prof, in your opinion on disposable cutlery, crockery? Absolutely not. The virus is very, very sensitive to heat. It's an envelope virus. It is very, very sensitive to heat. 60 degrees, 70 degrees, absolutely fine. No need to have disposable anything. Nothing. Okay? No clothes, no linen, no this, no nothing disposable. It is just a bad flu, guys. I mean, that's all it is. It's a nasty flu. And if we every winter threw and dumped everything that we had for people who came in with respiratory disease, we'd probably all go bankrupt. So the answer is no, ordinary. If you need to think about it, you will understand that if it's droplet, how could cutlery and crockery affect the droplet issue unless you move it around and aerosolize it, which you're not going to do. Okay, good. And so there's somebody says that is there the meeting? Sorry, oops, it keeps moving. Okay. So then will this meeting be available at a later stage for review? Somebody has asked, and the answer is yes. Thank you. And then we will try and do the best we can. Andy, what do you say to that?
Yeah, absolutely. I think that should be a follow-up meeting, okay, and we see what is happening.
Okay. And then Bimbo said, thank you very much. Great presentation. And also, can we share the PP? We can, but it is very South Africa driven. Okay.
I know.
And I'd be delighted to share it with you. But when we finish here today, we have a meeting with the minister at 5. He always calls it 6 or 7 in the evening. So we're going to have that meeting. And if there's a change to the program, we change the way it goes. And I think all of us are saying we're in the line, but I'd be happy to share it. It's not a problem. We have Ninette is asking, we have a lot of people ask about the biometric clock machines as a source of infection. Don't understand. What's a biometric clock machine? Yes.
When you come to work, you do a fingerprint clocking in. Some hospitals have got that fingerprint clocking in. That's what the biometric machine is.
Yep. Oh, I know the biometric. Oh, yeah, now I understand what you're talking about. No, that's fine, because after they've done that, they can just wipe it over with an alcohol swab between each person if they're concerned. In South Africa today, the ski holiday together. Okay, right? Just remember that. At the moment, that's what we've got. We haven't got any local transmission. We've got common source transmission. Remember that. If we see any local transmission, then we're going to go into gear 2 and move into a slightly different thing. What we're trying to do at the moment, or what the main aim of our program is at the moment, is that you contain everybody who comes in as an outside source person. Yeah. And I'm sure there is more to what Bimbo said. I think it'll be very interesting to talk to her offline to say, how did this chap get that virus from that other person? Because if it was at the end of 7 days, there must be something else going on, or there has been another outcome from somewhere else. And that's a separate, that's not for here, that's for another discussion. Okay, so they've also said, so the biometric clock machines, I think that's all I'm going to suggest is please ask somebody to wipe it down with the wipe, with just an alcohol wipe between people. Marcelin says, I've heard that in some places cloth cloths being used. Is it recommended as a substitute where there's shortages? And the answer is no, it's not, because once you use a cloth, it'll absorb the droplets and therefore you will have exposure to virus. The thing about the face mask is that it's actually got 7 layers inside it, as you know from your training, Marcelin, whereas the N95 is a lot more. So the answer is no, but it's better than nothing. Okay, at least it's better. Wearing a cloth would help with the face, because I think a lot of the stuff that they're wearing around Asia, I think those are cloths. I think they're made of cloth. But if you're in a health environment, I'm strongly going to recommend you use a face visor shield type thing. So if somebody said to me, would you rather have a visor or a face mask? Or said to you, would you have a visor or a face mask? The choice is yours. What would you go for? Sorry? Sorry? Did somebody say something?
Oh, see,
Prof Mehtar, I think that we have a lot of questions. You've addressed many of them. We thank people for their participation and their active discussion. So we'd like to invite all of you to join us on the next coronavirus presentation, and that will be communicated to you very shortly. So Prof Mehtar, thank you very much for your time, your expertise, and this very interesting talk.
So Adi, thanks. Thanks for the talk. Adi.
Yes, Linus?
Yeah, I was just thinking if we could ask people to actually present their cases, what they have found, like Mehtar has done, Prof, then we can all continue learning from each other. That would be very encouraging.
Yes, we'll follow up on this, and we'll make sure we have enough presentations on coronavirus from Africa. So ICAN can actually lead these presentations.
Thank you.
Yeah, thank you so much. We are really very pleased to see the interest you've shown on this presentation on coronavirus, which is a very hot topic these days worldwide. And we keep you posted on the next presentations on the same topic or with different aspects on coronavirus. Thank you so much and keep well. Prof Mehtar, are you back?
Bukan,